Greetings of the day. There is no potential conflict of interest with respect to this presentation. Topic of my presentation is mandibular incisor extraction, an orthodontist shot in the arm. This is my institution at Punjab University, Chandigarh. So extraction of healthy teeth has been a treatment alternative for orthodontists for quite some time. Baudret in 1757, a disciple of w.r.t, recommended the extraction of premolars to relieve the crowding. Similarly, Hunter extracted first premolars to allow incisor protrusion in case of posterior protrusions. Almost 2 centuries later, Hahn in 1942 advocated the removal of mandibular incisors to close the space and thus reduce the anterior dentition. Till that time, anterior dentition has been a sacred area where nobody will want to extract any teeth because of anterior dentition being an aesthetic zone or kind of a social six area, very much visible in the frontal smile region. So it was a kind of sacred area. So no one has thought of doing any extraction in anterior teeth. So Hahn has advocated the first removal of mandibular incisors. This procedure afforded lingual movement and elevation of the anterior teeth and helped to correct the class 3 malocclusions. So extraction of the lower incisor constitutes a therapeutic alternative in treating many malocclusions. It is not a standard approach to symmetrically treat many malocclusions, but in certain clinical situations, the therapeutic aims must be adjusted to individual patient needs, even when this means that achieved final occlusion is not ideal. So Kokich and Shapiro has pointed out that deliberate extraction of a lower incisor in certain cases allows the orthodontist to improve occlusion and dental aesthetics with a minimum of orthodontic action. So what are the indications for mandibular incisor extraction? So in class 1 cases, where severe anterior tooth side discrepancy greater than 4.5 millimeters is there, which can be due to agenesis of incisors or a deficient mesodistal diameter of upper incisors, or conversely, it can be because of a excessive mesodistal diameter of the mandibular incisors. Similarly, class 1 malocclusions with normal maxillary dentation and lower anterior crowding, and also class 1 malocclusion with anterior cross bites are the indication for class 1 cases. In class 2 regional malocclusion, where there is a maxillary protrusion and crowding or protrusion of the lower incisors. So lower incisor extraction should be associated with extraction of maxillary premolars while keeping the class 2 molar relationship but establishing a normal canine relationship, as we see in the cases which will be followed in this presentation. Similarly, another indication for class lower incisor extraction is class 3 malocclusions with anterior crossbite or incisor with edge-to-edge relationship, showing a tendency toward anterior open bite. Malocclusion with malformed or periodontally compromised incisors whose maintenance would not provide any benefit whatsoever in view of the stability of the dentition as a whole are also indicated for lower incisor extraction. In cleft lip impalate cases where mandibular surgery has been performed and it was still not possible to establish a proper overbite and overj, rendering necessary the extraction of an incisor to foster stable surgical result. Cases in which we want to avoid increasing intercanine width in class 3 malocclusion as a non-surgical alternative and as a compromise solution in adult treatment or in relapse situation. So there are many indications, and one major thing to note here is that lower incisor extraction can be done almost in all the classes of malocclusion, whether it is a class 1 case, class 2 case, or class 3 case, depending upon specific indication though. But it is quite a versatile ability. Lower incisor extraction provides a versatile ability which can be performed in all the classes of malocclusion. So there are two major circumstances, or other three major circumstances which can warrant a mandibular incisor extraction in adolescents and adults, like severe crowding of the mandible but not the maxillary incisors, as just we studied in the indications. Mild anterior crowding, cross-bite with good alignment in the both arches. Similarly, midline diastema with little or no overjet are the major circumstances where one can think of mandibular incisor extraction. Then the contraindications are also there. The cases with severe overbite and horizontal growth pattern, bimaxillary crowding, no tooth size discrepancy in the anterior teeth, anterior tooth size discrepancy due to narrow mandibular incisors, and broad maxillary incisors, pronounced overjet. These are the contraindications for extraction of a lower incisors. Cases with triangular lower incisors, triangular refer to the shape of the incisor when the width of the incisor is narrow at the cervical margin and wider at the contact point. So they are triangular in shape. These will allow presence of or occurrence of black triangles at the end of the treatment if we go ahead with the incisor extraction. So that is why if we have triangular shaped lower incisors, we should avoid extracting lower incisors or mandibular incisors. And when the crowding is minimum with less than 3 mm lack of space, it should preferably be treated without extraction or by stripping the incisors to prevent the reopening of spaces and loss of interdental gingival papilla between the remaining incisors, which might compromise aesthetics. So cases with diagnostic setup demonstrate where the diagnostic setup demonstrates that the lower incisor extraction can result in excessive overbite, and they are contraindicated for lower incisor extraction, and also cases which have a high insertion of the lower labial frenum and which can cause gingival recession in the remaining incisors to be moved in the frenum area. So there have been major objections, rather three major objections in extraction of mandibular incisors. First is the possibility of unsightly black triangles because of loss of interdental papilla height, which we will study how it can be prevented if a case is otherwise indicated for lower incisor extraction. The possible tooth size discrepancy that would affect the occlusal relationship, and a patient concerns about visible extraction site. So these are the major objections which can need to be taken care of while thinking of planning the lower incisor extraction. So advantages, although there are contraindications, there are many advantages with respect to lower incisor extraction. It maintains or reduces intercanine width, maintain the overall arch form, minimizing or preventing its expansion, preserving supporting structures, and increasing the potential for greater stability. It reduces the tension time as the likelihood of relapse is decreased. Quickly retracts anterior segments, so practically lessen the treatment time. Diminishes the risk of anchorage loss since there is a solid anchorage unit in the posterior segment. Reduce the need for elastic use. This is especially important for children or parents with behavioral disorders or non-compliant individuals. Similarly, lower incisor extraction also provides space in the area of greatest crowding in the pre-treatment stage, improve parallelism between lower interior tooth roots and reduce root proximity. Mandibular incisor extraction allows a reduction in tooth volume, minimizing changes in profile while reducing treatment time. It allows orthodontists to improve dental occlusion and aesthetics through minimum orthodontic action. So basically, lower incisor extraction can reduce the timing of orthodontic treatment, and also it can provide these many advantages in terms of maintaining the incisor intercanine width, improving parallelism between the lower anterior tooth roots, and providing space in the area of immediate greatest crowding in the pre-treatment stage. So Levin has argued that lower incisor extraction can improve facial profile by reducing the appearance of mandibular protrusion. It enables easy alignment of the lower interior teeth. It establishes an aesthetically pleasing and functionally effective overbite, and it properly positions upper interior teeth with acceptable axial inclination instead of having to procline them. So there are disadvantages also of extraction of lower incisors. According to Brandit and Saperstein, there's a tendency for space to reopen in the extraction site, which can be easily prevented by putting up a fixed spiral wire retainer, especially when a lower central incisor is extracted, irrespective of the parallelism between the roots adjacent to the extraction area. The incidence of space reopening is common. It can create a tooth size discrepancy, especially if lower incisors extraction is associated with premolar extraction. There may be differences in the color between lateral incisor and the canine, which are often darker, so this can be particularly concerning to the female patients. Other undesirable effects include increased overbite and overj beyond acceptable limits, partially inadequate occlusion, crowding or relapse in 3 incisors, as well as aesthetic loss of interdental papilla in the extraction area. And removal of a lower incisor also affect the interocclusal relationship of anterior teeth. If the upper anterior teeth are not sufficiently reduced through stripping, a more pronounced overj may remain. So according to Canot, in certain cases, especially in adults, space cannot be completely closed or can easily reopen, resulting in a visible diastema in an area of considerable periodontal and aesthetic importance. Moreover, an inadequate dental midline relationship compromises dental aesthetics. Sheridan and Hastings argue that a remaining triangular space may appear in the extraction area, especially in the older patient, because they already have a crestal bone loss and a loss of papilla is there. So in those cases, if we are doing extraction of lower incisors, there can be opening of black spaces or triangular space called black triangles. Now, next is the selection of the incisors which need to be extracted in cases where we want to extract the lower incisor as a part of the treatment. So for many authors or for many clinicians, it can be a toss of coins, but however, there are factors which can influence or which can decide or help to decide which incisors to be extracted. The indication will depend upon what type of malocclusion is there, where is the amount of anterior discrepancy present, and dental and health conditions of the supporting tissue and the upper and lower dental midline relationship. These are the factors which will determine which tooth to be extracted. And also, type of malocclusion and periodontal tissue health may influence the choice of tooth to be extracted, since if the tooth is diagnosed with ankylosis, tooth operation or severe ectopic eruption, far away from its normal position, it becomes the best option. Extraction of the worst position incisor is a means to prevent a relapse by limiting the unnecessarily movement of many teeth. Bolton tooth size analysis may assist in determining the discrepancies and asymmetries in both arches, thereby establishing whether the best indication would be the removal of the wider lateral incisors or the narrower central incisors. Some professionals still prefer to remove narrower central incisors, arguing that it promotes stability, especially in cases with less crowding. So Neff has reported that he prefers extraction of lateral incisors because he feels that the distal face of a central incisor has a better contact with the mesial surface of the canine. So he further explains that when extracting a central incisor, contact occurs between the mesial surface of remaining central incisor and the mesial surface of the lateral incisor. And even if the teeth are perfectly upright and parallel, sometimes an undesirable black triangle remains between the middle third of the tooth and the gingival. So, according to different authors, there are different ways to select which tooth to be taken out. But instead of going by a cookbook approach of taking out one particular tooth in all the cases, it will be a better option to decide which tooth to be extracted in each case, depending upon the patient presenting conditions and the amount of space required to be utilized for the treatment, rather than sticking to one person approach that we will extract lateral incisor only, or we will always extract the central only. So diagnostic setup is a very important tool which can help to decide about the lower incisor extraction. Also, it can tell you what kind of occlusion to expect after treatment. So setup is a diagnostic tool that shows orthodontic treatment outcome in study models to aid in determining the best treatment option. One can simulate various treatment options, such as without extraction, with stripping, with increased examination, with premolar extractions or associated procedures. Kokich, Shapiro, and Tiverson has summarized the importance of setup as one of the most valuable orthodontic records to determine if a lower incisor requires extraction. The setup is most accurate method to predict potential interclusion relationship to be accomplished through orthodontic treatment, and it would be reckless to start treatment without first reviewing the overj and overbite that would result from such procedure. It should be emphasized that if overbite is excessive or buccal occlusion is unacceptable in the setup, stripping the upper arch should be considered within the acceptable limits. If the occlusal outcome remains dissatisfactory, then probably extraction of an incisor should not be the treatment of choice. Then we come to how the lower incisor needs to be extracted. Although one can very well startled by this kind of a question, but there have been like for many, we have done in many cases lower incisor extraction and found that directly extracting the lower incisor can compromise the aesthetics upfront while the treatment is going on, and also there are more chances of appearance of black triangles after incisor extraction removal due to gingival recession and remodeling of the crestal bone. So these are the complications which we feel are there when we directly extract the lower incisor. The other option or other method of extraction is the extraction of lower incisor is by extraction site preparation, which we will see in our cases. So coming to the cases, the first case is SG, class 1 jaw basis with normal-divergent growth pattern. She has a complaint of midline diastema, which was almost 3 to 4 millimeter in magnitude. So there was a bolting discrepancy, very little of it was there, 0.8 millimeter. So you can see otherwise her profile looks almost all right, except that she has a midline diastema. If we see the cephalometric values, class 1 jaw basis with the beta angle of 30 degree and NB angle of 3 degree. These are the intraoral pre-treatment and during treatment pictures. So pre-treatment picture shows the midline diastema and like angle class 1 buccal occlusion on both sides with molar in class 1 and canine in class 1 relationship. So there was no overj where we could have, which could have been used to close the space of midline diastema. So we decided to extract lower incisor, and this is how the treatment progressed. You can see now the space of the midline diastema and in the lower incisor extraction space is almost same, and buccal occlusion is well maintained on both sides. This is the intraoral occlusion photographs of the pre-treatment, the same patient. These are pre-treatments. You can see there was a little bit of crowding and there was no overj which could have caused this midline diastema to close. So that was one reason. So in this patient, the extraction of lower incisors were done by incisor site as extraction site preparation. What is extraction site preparation? In this, the tooth to be extracted is moved lingually and other teeth are squeezed into that space. And when the space is almost to be closed, then we extract the lower incisors. So that is extraction site preparation, and it has been reported that it preserves the bone and prevents the appearance of black triangle in this area of lower incisor extraction. These are the stage pictures, the same intraoral pictures. Corresponding to same intraoral pictures. Another patient is AG. She's skeletal class 2 jaw basis with normal divergent growth pattern. Angle class 2 with 6 millimeter overj and 70% overbite. So you can see typical class 2 patients with an NB of 6.2 degree. So intraorally, you can see both on both sides there was end-on-molar relationship almost, and almost end-on canine relationship on both sides, and a lot of crowding in the maxillary dentation. So it was not a very typical of a class 2 D1 case. Normally, class 2 D1 case doesn't present this kind of incisors. So in upper arch, the discrepancy was more, so we have to extract the upper premolars, first premolar on both sides, and lower incisor has to be extracted to manage the lower crowding, as we will see in the intraoral occlusion pictures. So this is the intraoral occlusion picture. You can see. So lower incisor was blocked out, 3-2 was blocked out, and this is how the treatment is about to be finished. Lower arch has been recently debonded with a permanent retainer in place. So from canine to canine, and we have seen in the previous slide that this well-settled class 2 molar relationship on both sides and class 1 canine relationship on both sides. This is how she looks like now, about to be debonded for the upper arch in the next sitting. Another patient, AK, is a history of childhood trauma to anterior teeth, failed treatment leading to extraction of 1-1-2-1-2-2, bridge from 1-2-3, replacing only 2 lost teeth, being treated by closing the space of 1 incisor, simulating premolar extraction and lower incisor extraction. So this was the case. You can see this is a bridge from lateral incisor of that is 1-2-2-3, replacing only 2 missing teeth. And still the patient has a lot of overj or a lot of population of upper and lower teeth. So we have to remove this bridge. We plan to cover up the space of 1 orthodontic and extract the lower incisors. We don't have the intraoral pictures right now because of some issues with the patient pictures. So this is how it is going on. Right now, we have already debonded the lower arches. Somehow the photographs are not available, but this is how this is a riding pointing in place, which is being reduced in size. And from here, full size to now, it is almost, the space is closed. And this patient is now ready for processing in the upper arch, where only 1 incisor will be placed. So these 2 canines will become lateral incisors, and these 2 central will become lateral, and this process will become the central incisors. This is another patient, NB, with skeletal class 3 jaw basis, protrusive mandible with normal divergent growth pattern. Dental is angle clasping type 1 malocclusion with midline diastema. So you can see class 3 profile almost straight when we look at external pictures, but cephalogram shows that the mandible has a slight tendency to overgrow the maxilla, and mild class 3 problem is there, as illustrated by -2 ANB degree, -2 ANB angle. These are the intraoral pictures. The patient chief concern is midline diastema. You can imagine how can you close this midline diastema when the class 3 problem is there. Already there was a compensation in the lower incisors. So this is how we have taken out 1 incisor, 3-1 in the mandibular arch, and space closing is happening. These are the intraoral occlusion pictures. There was some crowding in the lower arch as well. So the incisors extraction serves dual purpose of resolving the crowding, managing the class 3 problem, and helping to close the midline diastema. These are the post-treatment pictures. Patient is still under treatment, about to be debonded in 2-3 months time. Another patient as such, again, skeletal class 1 jaw base supplementarily, but appearance-wise, she is a mild class 3 patient with hyperdiagonal growth pattern. Dental is angle class 1 type 1 malocclusion. So you can see a little bit mandible profile prominence, or otherwise pleasant profile. ANB of -1 degree. So perfect class 1 molar relationship on both sides, right and left, with a lot of crowding in the maxillary arch and the mandibular arch. Since it was a kind of mild class 2, we thought of compensating the upper arch by declining declining the upper incisors, and in the lower arch, as we see in the lower intraoral occlusion pictures, you can see that a lot of crowding is there in the lower arch. So we extracted the 3-1 here. It was also extracted in the same way, like by extraction side preparation. So 3-1 was moved lingually inside, and then the space for other teeth were squeezed into that space. And once the space was about to close, then the extraction of the incisor was done. This is how she looks like now. Already she is about to be debonded. So in conclusion, as the number of teeth to be extracted is a big concern for every patient, lower incisor extraction is literally a shot in the arm for orthodontists. It is more so in today's time, as there are many adult patients who are looking for quicker and conservative treatment options. And it is more so because there are chances of having compromised tooth and dentitions in those patients. So possibility, one biggest advantage is of lower incisor extraction is the possibility of this possibility of doing in all the angle glasses, like class 1 malocclusion with broken discrepancy, and class 2 malocclusion with where you can extract upper 2 premolars and lower incisors, and class 3 malocclusion with H2H incisor relationship. Extraction of single lobe will produce great treatment results. So reduction of 1 tooth from 4 premolar teeth to 3 teeth in the class 2 case is about 25% reduction in extractions. This is readily acceptable to many patients. It's quite a practice builder. So from practice management point of view, when you say the patient that instead of 4 teeth, we will be extracting only 3 teeth, so it is readily become acceptable to the patient. So most of the disadvantages which are related to lower extractions can be managed by various means, and midline concern in many cases is not there because the visibility of lower is not there. Of course, when the visibility is there, then it may be a concern, and in those cases, one can avoid extracting the lower incisors. And last but not the least, the option of lower incisor extraction in many cases can be sort of middle path when the crowding is not that severe to warrant 2 premolar extractions, or not so small that it is possible to manage the patient without extractions. So with this, we come to the end of my presentation. So for any queries, you can write to me at my email ID. And I would like to thank the organizers of 55th Indian Orthodontic Conference and the Indian Orthodontic Society for providing this virtual platform to present my experience about lower incisor extractions. Thank you very much.